Welcome to Tuned In with Mike Johnson, a public service of Mount Wilson FM Broadcasters and Global Jazz Incorporated. Now, here's Mike.
Thank you, Al Verdi, and good morning, everybody. Welcome to Tuned In from Mount Wilson FM Broadcasters and Global Jazz Incorporated. This morning, our topic is prostate cancer awareness. September is National Prostate Cancer Awareness Month, and my guest this morning is going to be Dr. Mark Stein with RadNet. Aside from melanoma skin cancer, prostate cancer is the most common cancer among men in the United States. It's also one of the leading causes of cancer deaths among men of all races and Hispanic origin populations. American Cancer Society estimates for prostate cancer in the United States are over 164,000 new cases of prostate cancer and about 29,000 deaths. This is a shocking number. We have Dr. Mark Stein from RadNet in Orange County with us this morning. Doctor, good morning.
Good morning.
Thank you for being with us. You know, the idea of prostate cancer, I think people maybe have some vague idea about it, but they may not know everything. So, doctor, what is prostate cancer?
Prostate cancer is a tumor of the prostate gland, which is a gland that, for your listeners who don't know, sits below the bladder in male patients, and is a gland that produces fluid for the patient, and it basically is a male organ only, and tumors of the prostate gland are usually malignant tumors. That means that they may spread, but they are different types, and this is something that's become very important for people to be aware of, that though you have prostate cancer doesn't mean that you're going to die from it.
And you know, cancer just into itself is, of course, such a scary word. When you have to tell people that they have prostate cancer, do most people think it's a death sentence?
Most people hear the word cancer and believe that it is a death sentence.
Yeah.
It is certainly not in the year 2019 a death sentence by any means.
So, doctor, now what are the signs or symptoms that people would have to look for prostate cancer?
Well, the early warning signs for prostate cancer are actually often none. The vast majority of patients who have prostate cancer have very few symptoms. In fact, by the time they have symptoms, it's maybe more problematic, and in fact, this is one of the reasons you and I are talking. But the early signs of prostate cancer may be, and these are not specific, I want to be real clear about that these can be caused by other things within the prostate as well, besides prostate cancer. They include burning or pain during urination, difficulty in urinating, more urgent needs to urinate during the night, waking up more often, loss of bladder control, decreased flow or stream of the urine, blood in the urine, or blood in the patient's semen. Now, I want to stress that the vast majority of patients who have this do not have prostate cancer, but these are some of the very early signs, and they are signs why patients who have them should go and see their referring physician, their primary care doctor or urologist, because these may be signs of prostate cancer, or more probably they are signs of either an infection of the prostate or of an enlarged prostate, all of which need to be taken care of.
You know, it really is about knowing your body. And if there's something that seems just a little amiss, it really is a good idea to go get yourself checked out, shouldn't you?
Yes, it is, actually. And this is actually a very timely discussion, and I think we'll come back to it later, is screening for prostate cancer.
So, doctor, now, are there things that can increase your risk of developing prostate cancer?
Well, there really are some, they say some dietary things, but there really aren't any specific things that will say that you need to avoid prostate cancer. Prostate cancer is very common. In fact, 1 in 9 men will be diagnosed with prostate cancer during their lives.
Wow.
However, it's even worse than that. Approximately 80 to 90% of men ages 80 or older will have prostate cancer. If you had a look at the prostate and could analyze it, you would find signs of prostate cancer in these patients, even though it's not going to do anything for them. But 1 in 9 patients will be diagnosed with prostate cancer.
So as you get older, does the preponderance for it happening just kind of grow as you age?
Yep. In fact, I happen to have some statistics for you.
Okay.
That young adults between ages 19 and 40 years of age, it is very, very rare. Between ages of 41 to 60, it is actually common. And those are the ones that we really want to pick up, because those are the ones that will cause long-term problems for the patient. Seniors aged 60 and older, it's very common. Now, a lot of those, they're not going to feel any ill effects. It's probably not going to be the cause of death, but they will be diagnosed with it, and then the decision will have to be made as to what do you do about it.
Well, I mean, and you tell me how this works, doctor. If let's say you're a 60-year-old man and you're diagnosed with prostate cancer, can it spread everywhere? I mean, is it centralized? Is there a kind of a natural flow for how it goes, or is it sort of vary from patient to patient?
It can vary from patient to patient,
yeah.
And the most important thing is what we call the grade of the tumor, particularly in patients 40 to probably 70, 75, and even older. So prostate cancer comes in all flavors. Okay. There can be a very benign form that's not going to spread, and there can be a very malignant form that will spread. And the good thing with prostate cancer from a knowledge point of view now is we have a very good idea of which patients are likely to spread and which ones are not likely to spread. And what we do there is patients who have a diagnosis of prostate cancer will get a grading, and the grading is called the Gleason grading. Gleason is the person who described it originally and is not obviously very important, but that is the grading system that we use. And the higher the number of the Gleason grade, the more likely the cancer is going to spread. So if you have a very low Gleason grade, like about 4 or 5 or 3, the chances of it spreading are very, very slight. If it's a higher grade, for example, 8, 9, or 10, it's very likely to spread. So this is a cancer that we have a very good idea of how it's going to behave once we make the diagnosis.
My guest is Dr. Mark Stein. He's with RadNet. We're speaking this morning about September being National Prostate Cancer Awareness Month. This is tuned in from Mount Wilson FM Broadcasters and Global Jazz Incorporated. So, doctor, the diagnosis of prostate cancer, how does that begin?
It begins usually with a physical examination. This is the recommendation that patients over the age of 40 have a rectal examination to feel the prostate and feel if there are any lumps. The second way it can be made is using a blood test called a PSA, prostate-specific antigen, and there are some other blood tests that people do as well. If these are elevated, then the patient will have a biopsy. This is the way that it is being done right now. So in general, it's an elevated PSA or a physical examination or very unusual symptoms of spread. So, for example, a patient may have a chest X-ray showing lung nodules, or an X-ray of a bone showing a spread to the bone, what we call a metastatic deposit. But the vast majority of patients are from a rectal examination or from an elevated PSA or one of the more recent blood tests that can be performed, and there are numerous ones of these. There is also a way of looking for the prostate-specific antigen and other enzymes within the urine that can show that a patient is at risk for prostate cancer. Once you have that high risk or the suspicion, then patients undergo a biopsy. And I think this is where there's some really new and exciting information that's out there that's becoming well-known and becoming standard within the community.
Who should get screened for prostate cancer? Should every man, once they hit 40, get checked?
Every single man should have a rectal examination. And the use of PSA is controversial. The American Urological Society stopped using it about 10, 15 years ago.
Why?
And is now, because there were too many false positives.
Okay.
And the problem with PSA is that as you get older or the prostate enlarges from causes other than prostate cancer, the PSA can elevate. And that can lead to a false diagnosis or a false suspicion. But I still believe that the use of PSA is of value in patients, but this is something they need to discuss with their referring physicians so that they understand the risk and benefits of it.
So now for people who are diagnosed with prostate cancer, what are the treatment options?
Well, the treatment options are actually incredibly varied.
Okay.
The first thing is if it's a very low Gleason score, and as I talked about, this is a low risk of spread, and the patient is 70, 75, or 80 years old, we know that that prostate cancer is unlikely to cause a problem for the patient in his lifetime. And what we sometimes do with those is recommend what we call active surveillance. So that sounds like a oxymoron, active surveillance.
Yeah.
but it's actually a very important way of following it. So patients who understand the risks, understand the benefits, undergo what's called active surveillance, where they will be biopsied and followed at regular intervals to ensure that the prostate cancer does not change, does not become a higher grade, or starts to spread. This is very common, and in fact, this is very important because you don't want to do some of the treatments for prostate cancer if it's not necessary, because there are side effects to the treatments. So it's like all medical procedures. You weigh up the risks, you weigh up the benefits. It's discussed with the patient and the physician, and an informed decision is made as to which way to go, whether you do surgery, whether you do some of the other local forms of therapy, or just do active surveillance. Now, if you decide that you don't want to do active surveillance, or the tumor is of a higher Gleason score and is more likely to spread, or the patient is younger, you can have multiple different treatments. The most radical and the most common to this day, and in a younger patient, is to remove the prostate, a total prostatectomy. And this can be done in two ways. One is an open prostatectomy, or more commonly now is using robotic surgery. And then there's the spectrum in between that, patients who have a localized form or a patient who doesn't want to have a prostatectomy. There are other ways of doing this where you can freeze just that area. You can do heat treatments of that area, and you can do localized treatments. This is not as common and is really reserved for those patients who cannot or will not undergo a prostatectomy.
Now, the prostate itself, it's about the size of a walnut. Is that correct?
In young patients, yes. In older patients, it can get even bigger. It can be size of a golf ball or even larger.
Okay. Have people who have the surgery, where they're having it removed or partially removed, are there after effects?
There can be after effects, yes. Significant after effects. This is not a procedure that one undergoes lightly.
Okay.
The vast majority of patients, however, in an experienced center, do remarkably well. The problem is that there are certain side effects that can happen. The first one is impotence. And one of the new forms, well, it's not that new, it's been around since the 90s, is to spare the nerves going to the penis so that you can still be potent after the surgery. But the most common side effect is probably impotence. This can be helped with some of the newer drugs and some implants, so it's not the worst thing, particularly in patients who have a high-grade cancer who are likely to die from the cancer.
Right.
So it's one of the side effects, as I said, risks and benefits that you discuss with the patient. The second most common side effect is incontinence. Now, temporary incontinence after a prostatectomy for a week or 2 weeks is very common, but incontinence is now much rarer, particularly if you do a prostatectomy. This is one of the reasons why patients will try local therapy if you can prove that the prostate cancer is localized. And that brings up a whole different topic that we could discuss is, once you have prostate cancer, is this throughout the prostate, or is this localized and can be treated with local therapy?
And I guess there's no easy answer to that now, is there?
Well, there actually is a relatively easy answer to that.
Okay.
Number one, the way we do this now, and this is about to change, I believe, and in fact RadNet is on the cusp of doing certain things that is, I think, going to change this. The way we do this now, you have an elevated PSA, you have risk for cancer. They go and do what's called a random biopsy, a 12-quadrant biopsy. They biopsy the prostate and look at what comes out. Now, there are problems with this, and the biggest problem with this is that you're only getting a small sample. You're not visualizing where the abnormality is. This is still the standard way of going, and I'm not going to say that this is going to change right now, but I believe it will. What I think we can do now, and we have a lot of experience, and in our centers and in RadNet we've been doing this now for over 10 years, MRI of the prostate. And MRI of the prostate is a really exciting test. It's not at present used for screening, and I can come back to that because that may change in the very near future. But it is used in patients who want localized treatment, or you want to stage the prostate cancer before you do a radical prostatectomy. So now if you do a 12-quadrant biopsy and you discover prostate cancers all over the place, you probably don't need the MRI because the treatment for that is going to be to remove the prostate.
Right.
If you do the 12-quadrant biopsy and it's only in one area, a prostate MRI may be of value because you could do local freezing or heating of the tumor. The third alternative is in patients who have an elevated PSA, and we do the biopsy and we don't find anything. And you repeat the PSA because that's the most important thing to do. Prostate cancer grows very slowly, so you can repeat the PSA usually in 2 to 3 months. And if it's still elevated, then you may want to do an MRI to see, is there a prostate cancer in an area of the prostate that we don't routinely biopsy?
Mm-hmm.
So there are areas of the prostate that are biopsied that were easy to find, but occasionally right down at the base, at the upper portion of the prostate, or right down at the bottom of the prostate, we may not biopsy that. And this is where MRI is really, really useful. And I stress this because patients who have an elevated PSA that do not have a particularly enlarged prostate, do not have an infection, and are at risk for prostate cancer, an MRI is very, very useful and is now the standard of care in a lot of these patients.
Is a prostate MRI kind of a new thing?
No. It's been around for 10, 15 years.
Okay.
It's become much more common and done better in the last 5 to 10 years. Our centers and the RadNet centers have been doing this now for up to 10 years, and in fact, it's one of the things that RadNet is really concentrating on for both, for a public service as well and to help out our urologists. So we have a very active prostate MRI program that is run both down here, up in L.A., and in fact up in Ventura County as well with Dr. Princenthal, who is the main MRI reader for that area. And in fact, we work very closely together with him down here as well. So we have a entire LA-wide prostate program with RadNet.
My guest this morning is Dr. Mark Stein. This is Tuned In from Mount Wilson FM Broadcasters and Global Jazz Incorporated. We are speaking about prostate cancer awareness because September is National Prostate Cancer Awareness Month. Doctor, there's one of the things, and you mentioned it earlier on the process, the exam. This can be very frightening to some men. Is that one of the biggest barriers why men don't get screened?
A rectal examination is not a comfortable procedure for most men. Mm-hmm. And this is one of the reasons I think that PSAs are being done, but I think it does not replace the screening rectal examination because a PSA can be normal and the patient can still have prostate cancer. It is not specific. If it's very high, that's a different story. Then you know that the patient may well have prostate cancer, but it also may have spread. So prostate cancer may have a normal PSA, and rectal examination is very important. There is a new thing that is starting to come out, and in fact RadNet has just become part of it, and that is a program that's begun on the East Coast. Now this is controversial, and I stress that, where we are starting to do screening MRIs on patients. There is a company called Ezra, which is a web-based program, an app-based program, where a patient who's worried about prostate cancer will call into a central area, will be screened, and then depending on what the screening questions have and what the patients, if they fit certain criteria, they will be called back and invited for a prostate MRI if they want it and it is not covered by insurance. And we do a screening prostate MRI. We are starting this program. It's also based that they are going to start looking with artificial intelligence at these patients, as well as artificial intelligence analysis of some of the images. The prostate MRI is a regular prostate MRI with one exception. We do not inject contrast on the screening. And I think this is going to be a way to go for patients who are worried about it, who do not qualify for insurance, or are just being screened for prostate cancer. I think the jury is still out as to whether this is going to be of value, but my suspicion is I think this is going to be very useful for those patients who want it.
Doctor, just so we have the background, how long have you been practicing now?
I don't think you want to know.
Oh, now come on.
I got my radiology boards in 1984. I am a body imager. I did my training at Cedars-Sinai and at University of California, San Francisco. And I've been with my present group in Orange County since 1988.
In the 30-plus years, though, that you've been doing this sort of work, the advances that you must have seen in the last 30 years, they have to be very encouraging, I would imagine.
Oh, it's unbelievable. To give you an idea, when I trained MRI, the first outpatient MRI was put into L.A. and Orange County in about 1984. And in fact, working with the medical director of RadNet, he was a resident with me at that time, and he's now the medical director of RadNet. He had done an MRI master's degree in physics of MRI, and we started, and I helped him work with MRI and the original MRI scanners. It's a radiology now compared to 1984 is not the same field. The advances in MRI, the advances in PET scanning, the advances in CT scanning, molecular imaging, it's just amazing. Which actually brings up something from prostate cancer. We now have a really nice nuclear medicine way of diagnosing spread of prostate cancer, which is a PET scan using a isotope called Axumin. And that is very, very specific for very small deposits of prostate cancer that we use when it's necessary and when it's going to change treatment.
I would imagine, as the way you're describing it, the sizes of the cancer is going to, of course, be very, very small or very, very large. I would imagine that the hardware like this to find those little finite, small molecules that exist in the prostate that are cancerous can be very, very beneficial.
It's even beyond that, because prostate cancer often is not a one cancer, not a single cancer. It is often what we call multifocal, and it may be in different areas of the prostate. And the grade of the tumor may be different in different areas of the prostate. An MRI is very useful because we can tell on MRI those tumors that are high grade and those tumors which are low grade very often.
As far as your experience in dealing with people who have experienced and are living with prostate cancer, does diet play into it or heredity?
Not really. I mean, there are some people who say that diet changes and hereditary is involved. I think hereditary is involved in a small number of cases, but the vast majority of patients are just your routine gentleman who's older than the age of 40 who just happens to get it, unfortunately. I wish we could say that if you eat a particular type of food, you're going to get prostate cancer. That is certainly not the case. And because your father had prostate cancer doesn't mean that you're going to get prostate cancer by any means. Or that your father didn't have it means you're not going to have it. That also has no bearing on the fact.
Sometimes men have vasectomies. Do vasectomies play a factor in this one way or the other?
There's some work that suggests that there may be a slight increased cancer risk with vasectomies. I don't think it's significant, and I don't think it may increase it minimally. But patients without or with vasectomy are at risk for prostate cancer. So I would not have a vasectomy on the basis of a risk of prostate cancer. You do the vasectomy for other reasons. I don't think it changes your risk that much that it would stop you from doing that.
So we have a friend here who's in the studio with us today, and he is 40 years old, and he is frightened of this concept and just does not want to go through the procedure. If you are developing prostate cancer at the age of 40 and do nothing about it, obviously not every cancer is the same. Some are more aggressive, some are slower moving. But again, the idea is to get checked as soon as possible once you hit 40, though, shouldn't you?
Pretty much, yes.
Yeah. How often after 40 should you be checked and rechecked, I should say?
I think at your routine medical exam, probably every year or 2 years, that you go for your routine physicals. That's the recommendation. I think the change may become that we may start doing screening for prostate cancer for those patients that we think are at risk or whose PSA is slightly elevated who don't want to undergo the biopsy. The procedure for screening for prostate cancer, the rectal examination, I want to stress people don't want to do it.
Yep.
It really is not bad. I've had it done many times, for that reason. And do I enjoy it? No, but it's certainly something that you do because if you can find it, it's curable. And I think that's what the most important thing is. For example, mammography for women is not comfortable.
Yep.
Most women dislike mammography, but we have convinced them, and I think we should have convinced them, that mammography is a useful screening test for breast cancer, and that the 2 minutes or 5 minutes for mammography of discomfort is worth it. For a rectal examination, it's a lot less time than that. And I think we, as males, probably need to understand this, that this is screening, this is something we should do for our health.
Now, I understand that there is a train of thought that says that you probably don't have to do this until you're the age 50 versus the age 40. What do you feel about that?
I think that's justifiable for some people. I think if you're having the physical exam, if you have the rectal, it's not that big a deal. I'm not sure you would go specifically to have a rectal examination between the ages of 40 and 50.
Right.
Just for that reason. But if you're having a physical examination, I believe, and I was taught, that this was part of a physical examination. When I went to medical school, this is what we were taught. You do a rectal examination. I think there are other reasons to do a rectal examination in patients ages 40 right now, is we have a higher incidence or a beginning of what looks like it may become an epidemic of colon cancer or rectal cancer in young men and young women. And this is starting to become alarming because these are bad tumors. So I think you get more out of the rectal examination than just feeling the prostate. You can pick up blood in the stool. You can feel masses in this area. I think these are reasons to do this.
Dr. Mark Stein, thank you for being with us this morning.
You're welcome. I appreciate it. Thank you for having me on.
Thank you, Doctor. This is Dr. Mark Stein. He's with RadNet in Orange County. And again, what we're doing this morning is we're speaking about prostate cancer because September is National Prostate Cancer Awareness Month. If you're a male, the concepts of having these exams may not sound very, very thrilling, but they could save your life. My name is Mike Johnson. Thanks for listening to Tuned In.
Thanks for listening to Tuned In with Mike Johnson. To contact Mike, email him at tunedinmj@gmail.com. That's tunedinmj@gmail.com. Or write Mike Johnson, Tuned In, P.O. Box 250028, Los Angeles 90025. Thanks for listening and staying tuned in.